Okay, guys. I'll go ahead and get started here, but I think there's only one person in the crowd I don't know, and it's a student. So, hello, my name's Hannah. I'm the PGY2 Critical Care Pharmacy resident, and today I'll be talking about pharmacologic adjuncts in hemorrhage control. I have no financial or personal disclosures, and by the end of the day or at the end of the presentation, I hope that you'll be able to describe the incidence, risk factors, and pathophysiology of trauma-induced coagulopathy, recall thromboelastography to identify coagulopathies and guide the use of pharmacologic adjuncts, and identify clinical situations in which the use of the following agents is appropriate in hemorrhaging trauma patients. And those agents we'll be discussing today are tranexamic acid, cryoprecipitate, prothrombin complex concentrate, recombinant factor 7, and calcium. Before we jump into the presentation, I just want to preface this by saying that anticoagulation reversal is beyond the scope of this presentation, and that the pharmacologic adjuncts used and mentioned in the presentation today are discussed in the setting of trauma hemorrhage control. So to start us off, I'll just be going into a little bit of a background and introduction on traumatic hemorrhage and hemostasis. So unintentional injuries are the fourth leading cause of death in the United States and the leading cause of death in people aged 1 to 44 years. And it's accounted for over 225 deaths in 2021. An estimated 25% of those deaths are directly attributable to hemorrhage, and hemorrhage is the primary cause of early death, which is defined as the time frame within 24 hours of injury. However, the mortality of the bleeding trauma patient is really highest in that 3 to 5 hour window. Patients with penetrating injuries like gunshot or stab wounds are more likely to die due to hemorrhage compared to patients who present with blunt trauma wounds. And damage control resuscitation is a comprehensive standard of care that aims to minimize blood loss and prevent and treat coagulopathy. Damage control resuscitation is a combination of environmental, procedural, surgical, and pharmacologic interventions. And the principles of damage control resuscitation are to avoid and reverse hypothermia, obtain early hemorrhage control with tourniquets or wound packing, to avoid excessive crystalloid resuscitation and utilize massive transfusion protocols, avoid delays in definitive hemostasis, so that would be like a surgical or an IR procedure, obtaining functional measures of coagulation, so that would be our TEG, to guide resuscitation. And then for the purpose of this presentation, we'll be talking about the pharmacologic adjuncts to promote hemostasis. Okay, jump scare, the coagulation cascade. I feel like everyone obviously usually hates this picture, but I think to understand the coagulopathies that are in trauma, and really to select the most appropriate hemostatic agent, we really need to understand normal hemostasis. So the coagulation cascade can be divided into 3 pathways: the intrinsic pathway, the extrinsic pathway, and the common pathway. In the intrinsic pathway, the extrinsic pathway, tissue factor comes in contact with blood as a result of endothelial damage, and then tissue factor will then convert factor 7 to activated factor 7. The intrinsic pathway is activated by exposure of coagulation factors to negatively charge vascular subendothelial surfaces. And then the intrinsic and extrinsic pathway will converge at the common pathway, which is in the final pathway of the coagulation cascade. The common pathway begins with the activation of factor 10, and that will ultimately lead to the formation of thrombin, fibrin, and the fibrin clot. So I think this image can help conceptualize the coagulation cascade at a more cellular level instead of just looking at what's going on with the factors and like the biochemistry. So in the cellular-based model of hemostasis, the overlapping events of initiation via the extrinsic pathway on tissue factor-bearing cells, amplification, which is a positive feedback of thrombin on platelets, and propagation of large-scale thrombin generation by the intrinsic pathway on activated platelets are regulated by cell surfaces rather than the protein components alone. So now that we've reviewed normal hemostasis, we can discuss trauma-induced coagulopathy, or TIC. TIC describes the abnormal coagulation processes that are a direct result of traumatic injury. Coagulopathy is present in 25 to 35% of patients upon arrival to the ED and is associated with increased transfusion requirements, organ failure, and mortality. In TIC, the balance between hemostasis and fibrinolysis is compromised, and it will usually manifest as a hypocoagulable state and a hypercoagulable state. And this will be kind of a spectrum of phenotypes. The magnitude of injury, time from injury, and presence of shock will all contribute to the severity of TIC. Historically, the lethal triad referred to the three interrelated physiological insults in trauma patients that will exacerbate bleeding and are associated with a high mortality. And the triad consists of hypothermia, coagulopathy, and an acidosis. However, in recent years, the lethal triad has been expanded to the lethal diamond or the lethal tetrad, and that includes hypocalcemia. So hypocalcemia occurs as a result of bleeding out calcium when patients are bleeding, but also due to the presence of the preserving agent citrate in blood. So citrate is present in blood products, and it will chelate with the blood product, the calcium that's in the blood product that's about to be transfused to the patient who's already hypocalcemic. So this picture is a lot and kind of overwhelming, but I just really want to point out the pathophysiology of TIC is complex, and it's a multifactorial process that's not fully understood. Defining a primary mechanism is also complicated by trauma being such a heterogeneous event with various contributing factors. So this image shows the pathophysiology of TIC, and I think it kind of represents a good or a visual representation of the mechanisms that are involved. And I'll break it down pretty simply, but as you follow along, just keep in mind that the blue boxes will represent hypocoagulopathy and the yellow boxes will represent hypercoagulopathy. So hypoperfusion and tissue injury synergistically activate the endothelium, platelets, and immune system. And in a hypoperfused state, such as blood loss or volume depletion, there's a reduced oxygen delivery to the tissues, which is ultimately going to result in a metabolic acidosis. Tissue factor is released in response to endothelial injury, which will activate the extrinsic pathway of the coagulation cascade, and that will result in thrombin and fibrin production. And then tissue injury will also release damage-associated molecular patterns or DAMPs, and that will stimulate the inflammatory pathway. Activation of the endothelium, platelets, and the immune system will result in the generation of various mediators that ultimately lead to fibrin depletion, platelet dysfunction, and insufficient thrombin generation. TIC is often classified by its predominant phenotype. Early TIC generally occurs within the first 6 hours of injury and represents a hypocoagulable state. And patients in early TIC will have uncontrolled hemorrhage, and shock is generally thought to be the dominant risk factor. Following hemorrhage control, most patients will transition from early TIC to late TIC within 24 hours. And late TIC represents a hypercoagulable state and is characterized by increased risk of developing thromboembolic complications. In late TIC, the dominant risk factor is tissue injury, as well as if patients who present with early severe TIC. Although this is a spectrum, understanding how TIC develops over time is really important to understand and determine when hemostatic agents will be effective and also when they will be ineffective and potentially harmful. So this brings us to our first question. AT is an 80-year-old male who presents to the trauma bay after being found down by his neighbors in a pool of his own blood. The last thing the patient remembers is tripping and falling down approximately 8 steps outside of his house. On arrival, his core temperature is 94 degrees Fahrenheit, his heart rate is 109, his blood pressure is 109/61, and his pH is 7, and his ionized calcium is 0.89. Which of the following risk factors does AT have that increases his risk of developing trauma-induced coagulopathy? Yes. I don't know what you said, but the correct answer is D. Bree said it too. And that's correct. So D, hypothermia, acidosis, and hypocalcemia. So the trauma lethal diamond is comprised of hypothermia, acidosis, coagulopathy, and hypocalcemia. The next part of the presentation will be kind of going over how to evaluate coagulopathies and identify them outside of just knowing that the patient might be coagulopathic based on them being a trauma patient. Conventional coagulation assays or tests include PT, INR, APTT, and fibrinogen, and they describe the clot initiation phase of hemostasis. Conventional assays are inexpensive and clinicians are familiar with how to interpret these results and how to use them. However, they are limited in their ability to provide data on clot stability, to detect contributions from platelets, and to detect hyperfibrinolysis. And conventional assays can also take much longer to result and pop up through EPIC compared to global hemostasis assays. Global hemostasis assays or viscoelastic testing describes the clot initiation, clot amplification, clot stability, fibrinolysis, and platelet function. So you overall are getting a much more comprehensive picture of what's going on with your coagulation or your coagulation cascade, really. The advantages of TAG include its ability to provide rapid real-time results, and it provides a global assessment of coagulation. And it's also been found to reduce transfusion requirements and mortality when used to guide traumatic resuscitation. However, TAG is more expensive than your conventional assays, and they may not be available in smaller community hospitals. And really, I think the biggest thing is that because TAG is, I guess, a little bit newer, it's been around for a while, but really being seen more and more in the inpatient setting is that providers may not know how to interpret the results and then what to do once you figure out you have a prolonged R time, then what do you do with that information? So I think that's one of the biggest limitations to TAG right now. So how do we interpret TAG? I'm sure everyone's seen the little badge buddy. The results of TAG and ROTAM are displayed as both a two-dimensional graph that develops over time, as well as a numerical value that will pop into the chart in EPIC. The R time is the time it takes for a clot to begin forming, and a normal R time is anywhere from 5 to 10 minutes. Patients with a prolonged R time will have delayed clot formation, and they may require transfusion of coagulation factors like FFP. Functional fibrinogen maximum amplitude, or CFFMA, represents the strength of the fibrin clot, and reduced CFFMA values indicate fibrinogen deficiency, and patients might require fibrinogen replacement, usually in the form of cryoprecipitate. CRT-MA represents platelet fibrin clot strength, and a reduced CRT-MA indicates platelet deficiency. These patients might benefit from a platelet transfusion. And then lastly, the LY30 represents clot degradation and is reported as a % of amplitude reduction. And an elevated LY30 will indicate fibrinolysis and TXA might be warranted. Oh, sorry, forgot my picks. Okay, so although we most often are evaluating tags using the quantitative results that come in through EPIC, you might see tag tracings like these. And when we're resuscitating and talking about resuscitating a trauma patient, it actually might be more helpful to be looking at opening up Tag Manager and looking at the tag tracing in real time, just because you'll get an idea of how fast it's moving along, and you can kind of start seeing your picture faster than it would take for EPIC to upload all of it at once. So these are some examples of tag tracings. As you can see, a normal tag tracing is the top one, and it, I forgot what this is called, a brandy, is that what this is? I don't know what cup this is. Clearly I'm not a big drinker of whatever this is, but it's one of these like glasses that people drink out of. This one I can get behind. This is a tag tracing that looks like a wine glass will usually indicate patients who are anticoagulated or patients who are deficient in coagulation factors. This one, stay with me. So this would be tag tracing that kind of looks like a test tube might indicate platelet deficiency or at least ineffective platelets. And this would look like a test tube. And I was like, okay, maybe it's like a Halloween Jell-O shot or something. If we're gonna make it all alcohol. And then lastly, hyperfibrinolysis is typically thought of as being like an inverted martini glass. And then, so I included a lychee martini because this will be going to Dr. Mejia and he makes a good lychee martini. All right. So these are just a couple examples of tag tracings. There's all the tag tracings, depending on your patient, are going to look different, but just wanted to show you a few examples of how to interpret the tracing and not just the results. This brings us to our second knowledge assessment. MS is a 34-year-old male who's involved in an MVC. He's extricated and transported to the trauma bay within 30 minutes. Upon arrival, his blood pressure is 63/39, his heart rate is 124, and the massive transfusion protocol is activated. The tag is sent. The tag returns, and you see the following tracing, and the LY30 is 20%. What coagulopathy is present, and what would be the most appropriate treatment? Yeah, see. So the correct answer is hyperfibrinolysis and to give TXA. So this looks like, I guess it kind of looks like the martini glass. So the meat of this presentation is going to be spent reviewing the various pharmacologic adjuncts and used in the bleeding patient. Before I jump into the meds, I just want to mention our first line therapies. So actively bleeding trauma patients, really the cornerstone of therapy is blood and hemostatic control. So that would be like surgery or some sort of IR procedure. But really just outlining that these agents that we'll be talking about are helpful, but in a patient who's actively bleeding, blood is usually the right answer. So initial resuscitation will generally include transfusion of blood products, and those can be ordered as individual components, or it can be ordered via the via the massive transfusion protocol. We have two massive transfusion protocols at Erlanger. One uses whole blood, and one has uses the individual components. And there may be times in which the blood bank is out of cryoprecipitate, in which fibrinogen concentrate should be administered, and that would be ordered through the pharmacy. I'm sure all of the PGY ones are familiar with the cryo and what you need to do for massives. So the first drug that we'll be talking about is TXA, or tranexamic acid. And this one is the medication with arguably the most literature. So tranexamic acid, or TXA, is a synthetic derivative of lysine that binds to lysine binding sites on plasminogen, and this will prevent the activation to plasmin. This ultimately will prevent plasmin from binding to fibrin and subsequent fibrinolysis. TXA is generally well tolerated with minimal adverse effects, and the most serious adverse effects being hypotension with rapid infusion rates, dose-related seizures, and visual disturbances. Going into the history of TXA, it was originally developed in Japan in the 1950s and 60s by a couple, and it has since been used for many indications outside of trauma. However, TXA really gained popularity when the CRASH 2 trial was published in 2010, and since then, studies have continued to evaluate the use of TXA in trauma, with the most recent trial being published in 2023. I also want to point out here that CRASH 3 is definitely a landmark TXA trial that is often referenced, but it is studied and it uses TXA in the setting of TBI. And so therefore, we're not going to talk about it today, but I just want to include that so you're not like, where's CRASH 3? So get CRASH 3 out of here. So the first study we'll be talking about is CRASH 2, and this is considered one of the first landmark trials using TXA in trauma. It was a randomized controlled trial that took place at over 240 hospitals in 40 countries, and it included civilian trauma patients with significant hemorrhage or at risk for significant hemorrhage who presented within 8 hours of their original injury. Note here that patients were included if the treating provider was uncertain if TXA was indicated. So that means that they would be excluded if the provider thought that there was an absolute contraindication, and they were also excluded if they thought there was a clear indication for TXA. Patients were randomized to receive either TXA 1 gram as an IV bolus over 10 minutes, followed by a 1 gram infusion over 8 hours, or placebo. And overall, the baseline characteristics were well balanced, with the primary mechanism of injury being blunt injuries. And usually, so the rest of these trials throughout the presentation will really be using kind of like systolic blood pressure, and the Glasgow Coma Score, and as well as the injury severity score, which I'll talk about next. But those are going to be our surrogate markers for severity. So when you see these, you're kind of thinking to yourself, how severe is this patient when they're arriving to the ED? So as you can see here in CRASH 2, only 16% of patients were arrived to the ED with a systolic blood pressure of less than 75, and 18% of patients arrived with a GCS of less than 8. Over 20,000 patients were included in this trial, and the primary outcome was an in-hospital death at 4 weeks, and they found that TXA had a significantly lower mortality than the placebo group. The authors also found that the risk of death due to bleeding was significantly lower in the TXA group. Approximately 50% of patients received blood product transfusions, and the median units of product received was 3. And the incidence of at least one vascular occlusive event was low, and there was no difference in fatal and non-fatal vascular occlusive events between groups. And lastly, they found that that the number of patients without any symptoms at day 28 or at hospital discharge was higher in the TXA group compared to placebo. So indicating that these patients are have, I guess, little disability at discharge, and they're not severely, I guess, dependent on others. So a subgroup analysis also revealed that the most benefit was found in patients who received TXA within 3 hours, and patients with a systolic blood pressure of less than 75. And in fact, they also found that TXA that was administered past 3 hours was associated with an increase in mortality. So CRASH 2 was a great study because it was so large and it had really minimal protocol violations. And then also vascular occlusive events were appropriately diagnosed based on clinical signs and symptoms rather than just routine imaging and ultrasound. However, CRASH 2 wasn't obviously perfect. Most of these patients were from Africa, Asian, Latin American countries, and that really can limit generalizability to our patient population. We are generally thought to be a resource-rich area with more access than some of these patients might have had. Second, patients were included based on the provider's discretion and judgment. So this introduces the risk of selection bias. And lastly, patients really weren't that severe if we were looking at their Glasgow Coma Scale and their systolic blood pressure. And overall, only 50% of patients actually received a blood transfusion, and the median amount that they received was only 3 units. So the MATTER study was published 2 years later and was a retrospective cohort study that examined combat patients that were involved in a traumatic injury in an Afghanistan surgical hospital. And patients had to have received at least 1 unit of PRBCs in the last 24 hours. Mortality was compared in patients who received TXA and those who did not. And halfway through the study, as a part of the there was a initiation of a massive transfusion protocol. And you'll see when I present the results that it's breaks it down by the overall cohort and then patients who receive massive transfusion based on that protocol. The mean dose of TXA was 2.3 grams, which is mostly consistent with the 1 gram bolus followed by 1 gram infusion. And because it was retrospective, baseline characteristics were not well balanced. So I've kind of put them in a table so you can see it a little bit better. Patients with GSWs or gunshot wounds were not as likely to receive TXA, whereas patients who presented with explosive injuries were more likely to receive TXA. You'll also see that injury severity scores were similar between groups, but more patients in the TXA group had a systolic blood pressure of less than 90 and a GCS of less than 8. So I'll bring up the injury severity score here. The injury severity score is an assessment, a trauma assessment that kind of is used to define major trauma. And it looks at different organ systems and then the type of injury, and it will assign that a score. So the score ranges from 1 to 75, with 75 being the most severe, like dead. And then major trauma has historically been defined as a score of greater than or equal to 16. So the primary endpoint of mortality was broken down by time. And I've kind of blocked that out just so you can see that these are all part of the primary endpoint. At 24 hours, there was no difference in mortality between groups. However, TXA was associated with lower mortality at 48 hours and in hospital all-cause mortality. Patients in the overall cohort who received TXA were more likely to receive all of the blood products, whereas patients in the massive transfusion group were more likely to receive only cryo. Unlike CRASH-2, TXA was associated with more thromboembolic events in both the overall and massive transfusion groups. And in a multivariate regression analysis, they found that TXA was independently associated with survival in the massive transfusion group. So Matters answered the question regarding the utility of TXA in our more severely injured trauma patients who were already receiving transfusions. However, results are kind of limited based on it being a retrospective study. During the first year, they did the change of initiating that massive transfusion protocol. And so before then, it was kind of just up to the providers who got TXA and also what dose to use. Patients in the TXA group also received more PRBCs, FFP, platelets, and cryo, which may confound the mortality results. And then lastly, this was done in Afghanistan. And so the standard of care in Afghanistan during a wartime might be different than what our patients are receiving here. From CRASH-2, we saw that the greatest benefit comes from the early administration of TXA. So the rationale for the STAMP trial was to shorten the time to TXA even further by bringing it to the pre-hospital setting. The STAMP trial was a multi-center randomized placebo-controlled trial in trauma patients who were transferred from the scene or could be transferred within or to a referring hospital within 2 hours. And they were included if they had a single reading of a systolic blood pressure of less than 90, or if they had a single reading of a heart rate of greater than 110. The design of this trial was unique in that there were 4 treatment arms. So one group received placebo in both the pre-hospital and hospital phase, so they got placebo the entire time. The other 3 groups received 1 gram of TXA in the pre-hospital phase. However, in the hospital phase, they received either an abbreviated, standard, or a repeat bolus dosing strategy. And for patients who were in the abbreviated strategy, they received the pre-hospital bolus and then a placebo bolus once they got to the hospital and a placebo infusion. So altogether, they received just 1 gram of TXA. The standard group patients received the 1 gram TXA pre-hospital bolus, a placebo bolus, and then a TXA infusion, so 2 grams total. And then the repeat bolus group received all of it, so the TXA pre-hospital bolus, an in-hospital bolus, and an in-hospital infusion. Patients were well balanced in this trial, and the mechanism of injury was blunt trauma in 84% of patients. As you can see, the injury severity score was 12. So this really represents a less severe trauma population. There was no difference between groups for the primary outcome of 30-day mortality. However, when looking at the subgroup analysis of the primary outcome based on the dosing strategy, they found that the repeat bolus dosing strategy, which administered a total of 3 grams, was associated with a reduced mortality. The subgroup analysis also found a significantly lower mortality, which when TXA was given within 1 hour of injury in patients who presented with more severe shock, which was defined as a systolic blood pressure of less than 70. And there's no difference in any of the secondary outcomes, including 24-hour mortality, transfusion requirements, and thromboembolic events. So the STAMP trial was a major strength of the STAMP trial was that it highlighted that early TXA in the pre-hospital setting is safe. So really there wasn't any major difference in between groups for thromboembolic events. So it highlights the safety of TXA in the pre-hospital setting. Also, it investigated additional dosing strategies that were not previously studied by large randomized control trials. Unfortunately, the STAMP trial was underpowered for the primary outcome and only 93% of the planned enrollment was achieved. Patients were less severe based on their ISS score and the amount of patients who presented hypotensive. And then patients met criteria based on either that heart rate or the systolic blood pressure criteria. And so as you might expect, most of the patients met criteria based on the heart rate, which we know patients are probably tachycardic for a million other reasons besides their trauma or if they're bleeding. And the patch trial, we're getting there. So the patch trial was an international multi-center randomized control trial that included severe trauma patients that were at high risk for TIC based on their COAST score, and they had to have received TXA in the pre-hospital setting. So this is another, it's kind of similar to the STAMP trial, it's TXA in the pre-hospital setting. The COAST score is shown here just because it's not a score that we're all that familiar with, at least in the US currently, but it looks at different, I guess, variables. So they would be entrapment, systolic blood pressure, temperature, major chest injury that would require intervention, or a likely intra-abdominal or pelvic injury, and gives those scores. And the highest score possible is a 7. So patients who have scores of greater than or equal to 3 are considered to be high risk of coagulopathy. Patients were randomized to receive 1 gram of TXA over 10 minutes in the pre-hospital setting, followed by 1 gram over 8 hours once they arrived to the hospital, or placebo. And overall, baseline demographics were well balanced between groups, with the majority of patients' primary mechanism of injury being blunt injuries. And this really represented a more severe trauma population. So STAMP, less severe pre-hospital, patch, more severe pre-hospital. Their ISS score was 29. Their COAST score of patients who had a COAST score of at least 3, almost all of the patients, and almost 40% of patients had a systolic blood pressure of less than 75 on arrival. There was no difference in the primary outcome of survival with favorable outcomes at 6 months. So they, instead of looking at like the typical 28-day mortality or 24-hour mortality, they're looking at survival with favorable outcomes at 6 months. However, TXA was associated with reduced mortality at 24 hours and 28 days after injury. And at 6 months, mortality kind of evened out and was similar between groups. So this rainbow figure shows the extended Glasgow coma score at 6 months, and it indicates that almost all of the differences between the two groups was a shift from death. So death is the big red group, to a more severe, like the most severe, which is that yellow group. So patients died. This is really just saying patients died in the placebo group, which we knew, but more patients were left with severe disability in the TXA group. And lastly, there was no difference between groups in thromboembolic events, again, indicating the safety profile of TXA. So the strengths of this trial include that it was a population of very severe trauma patients. So it answers the questions that we had from STAMP as if this was applicable to severe trauma patients. And the primary outcome was patient-centered. So there's a movement towards having more patient-centered primary outcomes, and just really focusing in on what patients want to know will they be able to be disabled at 6 months or not. Limitations of this trial include that 35% of patients had some sort of protocol violation, including about 15% of patients in the placebo group getting TXA and 21% of patients in the TXA group not getting the entire infusion dose. Furthermore, the primary outcome data was missing for 13% of patients. So although this did give us a lot of answers about a severe trauma population, there's definitely some limitations that limit its use. And then the last trial is in the TXA section, at least, is going to focus on using TEG to define fibrinolysis. So it's not necessarily like looking at TEG, or looking at TXA, but it's more so looking at hyperfibrinolysis on a TEG, in which case we would treat with TXA, if that makes sense. So this was a prospective study that evaluated TEG assays in trauma patients who presented within 8 hours of injury and were likely to require massive transfusion protocol. 73 patients were included, and the population was generally a severe patient population based on their ISS scores. And then 30% of patients were hypotensive on arrival. Of note, the average ground transport time was 6 to 8 minutes. So this was much faster than the average in the US, which is right around 30 minutes. This was in the US, but just so you know, patients got to the hospital really fast. The authors of this study evaluated various LY30s to define hyperfibrinolysis related to the requirement for massive transfusion. And they found that patients with a LY30 of greater than or equal to 3 were at an increased risk of requiring massive transfusion. And although a LY30 of at least 3 was also associated with increased mortality, it had a lower positive predictive value compared to the massive transfusion group. So it really is, the LY30 is better at predicting massive transfusion than mortality. And so for this reason, this is kind of where the whole 3% as the cutoff for fibrinolysis came for. Like when you're looking at your like little badge buddy, you'll see the 3%. This is kind of where that's coming from. So this is more just for completeness sake and to kind of summarize all of the different trials, because we're going to talk about a lot of trials today. But this is just kind of a big overview of what we just talked about. So what should we do with all of that information? We know that TXA is inexpensive, and based on all of the trials we discussed, it has a low risk of thromboembolism. Further, it may reduce mortality when given to patients early in patients who have severe trauma. We also know that pre-hospital TXA is safe, but it shouldn't necessarily divert pre-hospital resuscitation resources or efforts. So if EMS doesn't need to like drop everything they're doing to give TXA, but it is safe to give in the pre-hospital setting. TXA can also cause a falsely low D-dimer, and this can be problematic because it might impair the ability to diagnose a VTE. However, we really wouldn't use a singular D-dimer to diagnose a VTE, but just something to be aware of. And then finally, there was no difference in survival with favorable functional outcomes as we saw in the patch trial. So based on this, it's recommended, or I'm recommending, to administer TXA as early as possible. So really within that 3 hours of injury in severely injured trauma patients, which is defined as a systolic pressure of less than 90, or if they're actively hemorrhaging, or if a patient has an LY30 of at least 3 on their TEG. Based on the results of the STAMP trial, at Erlanger, we give a 2-gram bolus followed by a 1-gram infusion of TXA to be 3 grams total. However, if the patient did receive TXA in the pre-hospital setting, you would just use like the 1-gram bolus. So again, it would total 3, but just being mindful if you are ever in the ED, just to ask EMS if they gave TXA. So that was a lot. So let's do a knowledge assessment. JM is a 30-year-old female who presents to the trauma ICU following an MVC with an extrication time of 2 hours. She becomes hemodynamically unstable in the ED and is taken to the OR emergently for an XLAP. She arrives to the ICU 2 hours later and her map begins dropping. The resident asks if TXA should be given. Based on this information, is this patient an ideal candidate for TXA? Yes, good job. So correct, the patient is not an ideal candidate for TXA because between the extrication time and the time she was in the OR, it's now been 4 hours. And so she's really outside of that benefit window. So moving on into our next product or our next medication, fibrinogen replacement. So fibrinogen is rapidly depleted in trauma due to blood loss, acidosis, hypothermia, and consumption, and when clots are being formed. The European guidelines recommend fibrinogen replacement if functional fibrinogen on a TEG is present or if plasma fibrinogen is less than 150. And it's just important to note fibrinogen is in various products. So it's in cryoprecipitate, it's in fibrinogen concentrate, and it's also in fresh frozen plasma or FFP. So I've kind of highlighted the differences between cryoprecipitate and fibrinogen concentrate because they are similar products. So with cryoprecipitate, it's derived from FFP, whereas fibrinogen concentrate is derived from large pools of human plasma. So it is still a human-derived product. So I haven't seen a Jehovah's Witness yet, but if you were to have a Jehovah's Witness, that would might be something that you would want to ask if they're okay with getting fibrinogen concentrate. FF or cryoprecipitate it comes from the blood bank, so they're going to have to thaw it, and it will have to be delivered from the blood bank. Often, I'm pretty sure that they have cryo that's available for like traumas, but that said, if you're like blowing through a bunch of cryo and blood product, or you have a lot of casualties or traumas that all come in at once, it might take a little bit of time if they need to thaw it out. However, fibrinogen concentrate is rapidly reconstituted. It comes from the pharmacy in a vial, so it doesn't require any thawing or delivery from the blood bank. And then lastly, cost. The cost of a cryoprecipitate is about $600 to $800 per massive transfusion protocol cycle, whereas the cost for fibrinogen concentrate is about $3,000 per cycle. So the first trial I'll be talking about as it relates to fibrinogen is the FEISTY trial. And this was a multi-center randomized controlled pilot study. And just really highlighting that this is a pilot study. It's not necessarily like a phase 3 or anything. But patients were included if they had a traumatic injury within the last 6 hours, they had clinically significant hemorrhage or potential for significant transfusion requirements, or they had an ABC score of at least 2. And they were randomized to receive fibrinogen concentrate or cryoprecipitate. The fibrinogen dosing was dependent on ROTEM, which is kind of like we touched on. We use TAG here, but some places use ROTEM, but a similar test. So that would just determine the dose that patients received. And then the mechanism of injury was blunt trauma in the majority of patients, and this patient population was more severe based on their ISS score. I'll also point out, so the ABC score is something that you might see when reading trauma trials, and it was developed at Vandy, and it looks at systolic blood pressure, heart rate, a FAST exam, and any penetrating torso injury, and a score of at least 2 would be criteria to activate MTP. Also, I just want to point out here that as far as like, because this was a pilot study and it was a small group of patients, which you'll see in a second here, it wasn't necessarily well balanced. So for patients who received fibrinogen concentrate, they had a GCS of 3 upon arrival compared to 12, GCS of 12 in the cryo group. So that's a pretty big difference. Overall, this was a small pilot study. So just again, interpret these results cautiously. But the primary outcome was the time in minutes from the ROTEM results to the administration of fibrinogen. And they found that the time to administration was significantly lower for fibrinogen concentrate compared to cryo. And in fact, the time from ROTEM to administration was twice as long for the cryo group. The median initial dose was 3 grams for the fibrinogen concentrate group versus 8 grams in the cryoprecipitate group, and just under half of the patients in each group required surgical or IR intervention. Although the fibrinogen concentrate group was administered more quickly, they had a similar pre and post infusion fibrinogen level, indicating that cryo is as effective as raising fibrinogen levels. 32% of patients in the cryo group experienced a vascular occlusive event compared to 19 in the fibrinogen concentrate group. However, mortality was much higher in the fibrinogen concentrate group. Again, keeping in mind that there was only 37 and 25 patients in each study. So really that this isn't powered to detect any differences for secondary outcomes by any means. So although FEISTY did give us good information regarding the utility of TAG, it was small, underpowered, and it just set the stage for future trials. So the big one that came up next was the CRYOSTAT-2 trial. So the CRYOSTAT-2 trial was an international multi-center randomized control trial that included patients with severe trauma within 3 hours of injury, and they had to have evidence of hemorrhage requiring activation of the massive transfusion protocol. And patients had to have at least been started, or at least 1 unit of blood had to have been started. Patients were randomized to receive 3 pools, which is approximately 15 units of cryoprecipitate or standard of care. So essentially that meant for this patient population or the included patients that they would receive the 3 grams or the 3 pools of cryo plus MTP if they required MTP, or just MTP. So they got that 3 pools right up front. The goal time to cryoprecipitate administration was 90 minutes. Again, baseline characteristics were well balanced. Most of the patients had a blunt injury as their primary mechanism of injury. And the injury severity score was 29. So again, indicating a severe patient population. And just noting that 20 or almost 100% of patients received TXA. For the primary outcome, there was no difference in all-cause mortality at 28 days in the overall cohort. However, patients with penetrating injuries who received cryo had significantly higher mortality compared to standard of care. So this graph illustrates the pre-specified subgroup analysis of mortality by injury type in patients who receive cryo versus standard of care. So the yellow lines will represent patients with blunt injuries. I guess that's a navy line, will represent the overall cohort, and the light blue line represents the patients with penetrating trauma. So for the 36% of patients that presented with a penetrating trauma, 28-day mortality was significantly higher in the cryoprecipitate group than standard of care. 28-day mortality was again similar between groups in the overall cohort and with blunt injury. There's no difference in any of the secondary outcomes, including neurologic outcomes, transfusion requirements, hospital or ICU length of stay, discharge disposition, or the incidence of thromboembolic events. So cryostat-2 answered an important question regarding the use of empiric cryoprecipitate in a severe trauma population where TEG might not necessarily be fast enough if you have a patient who's coming in and they are just crashing at the door. So it kind of answered the question as if this useful to start giving empiric cryo without getting a TEG. Unfortunately, there was a lot of protocol violation that can confound results. So in the cryoprecipitate group, only 68% of patients received their first dose of cryo within the goal time of 90 minutes. And only 85% of patients in the cryo group actually received cryo. So 15% of patients in that group didn't even receive the trial drug. Again, for completeness sake, I've summarized the trial. So we looked at the Feisty trial and the cryostat-2 trial. And so now what do we do? What do we do with cryo in our bleeding trauma patients? Keep in mind, cryo was associated with few adverse effects, including thromboembolic events, so it's relatively safe. And then also the Feisty trial showed us that cryo was as effective as raising fibrinogen compared to fibrinogen concentrate. On the flip side, empiric cryo has not been shown to improve mortality or functional outcomes, and it was not associated with a reduction in blood product consumption. And so based on our current literature, it doesn't support the use of empiric cryoprecipitate, but we should continue to use it as a part of the massive transfusion protocol, or if indicated by TEG, which you would see a CFFMA of less than 15, or if fibrinogen is less than 150. The next agent we'll be discussing is prothrombin complex concentrate, or PCC. And PCC contains vitamin K dependent clotting factors, so 2, 7, 9, and 10, as well as protein CNS. And it's thought to increase factor concentration and thrombin generation in patients with trauma who are at risk of massive transfusion. It's dose based on the factor 9 component, and FFP also does contain coagulation factors, but at a much lower concentration. So 6 units of FFP is thought to, or is expected to increase coagulation factors by 20 to 30%. There are several commercially available PCC products, and those are usually thought of as like 4-factor PCC, 3-factor PCC, or activated 4-factor PCC. And I've listed the components of each product, but the main difference between 4-factor and 3-factor is that 3-factor has minimal factor 7. As far as comparing PCC and FFP, because in most trials that are looking at PCCs, it's going to be compared to FFP because they both have coagulation factors. So when you're thinking about just how they compare, FFP requires thawing and delivery from the blood bank. And as we know, PCC is rapidly reconstituted and delivered from the pharmacy. FFP does require blood typing. It can also be associated with an increased risk of TRALI, or transfusion-related acute lung injury. It does pose an infection risk, and it can lead to dilutional coagulopathy just based on the amount of FFP that has to be given to replace coagulation factors. PCC doesn't require blood typing. That has a very low infection risk. However, it is contraindicated in patients who have HIT, whereas with FFP, patients with HIT can still receive FFP. And then lastly, the cost. So FFP costs around $300 to $500 for 6 to 10 units, whereas PCC will cost about $8,000 for one dose in about 100 kilogram patient. So the only trial that we'll really be talking about for PCC is the ProCoag trial. And this was the first randomized control trial that compared 4-factor PCC to placebo. It was a superiority multi-center randomized control trial that included trauma patients that were considered at risk of massive transfusion. And patients were randomized to receive 4-factor PCC as a weight-based dose of 25 units per kilogram or saline placebo. Blunt injury was, again, like all of these trials, is the primary mechanism of injury. And these patients were relatively severe based on their ISS score, and they had a median systolic blood pressure of 90 upon arrival. I'll also point out here that about 76% of patients in the PCC group received pre-hospital TXA versus 86% of patients in the placebo group. Again, indicating that pre-hospital TXA is standard here. This was done in France, by the way. So there was no difference in the primary outcome of total 24-hour blood product consumption between groups. Additionally, there was no difference in time to anatomic hemostasis, 24-hour mortality, and 28-day mortality. However, patients who received PCC were significantly more likely to develop a thromboembolic event when compared to placebo, and that risk was greatest in patients who presented with an INR of greater than 1.2. So usually we can think of INRs as how they relate to coagulopathy, and patients who are coagulopathic will generally have a higher INR. So trauma patients might have a higher INR. The strengths of this trial is that the majority of patients, so 95% of patients, actually received the study intervention within 1 hour of admission. And this was a superiority trial. So oftentimes we don't get that trial design. So it was nice to see that the PCC wasn't superior. Limitations of the trial was that a higher percentage of patients in the placebo group received pre-hospital TXA, and they also had a higher medium total dose of fibrinogen concentrate compared to the PCC group, and that could dilute the efficacy results of PCC. So as many of you guys know, and I think Cassie is in here, our TAP queen, Erlanger is participating in the TAP trial, and this is a really similar study, really looking at kind of the same thing as the ProCoag trial. So some of the main differences, so this is the design of the TAP trial. The main differences between ProCoag and TAP is that the type of PCC that was used. The primary outcome in the TAP trial is looking at mortality versus the primary outcome in the ProCoag trial was looking at blood product consumption. And then this is also a US study compared to the ProCoag was done exclusively in France. The go live date was last Friday, just so everyone's aware that it is live currently. So again, for completeness sake, a summary of the ProCoag trial. And what are the recommendations, or what are we recommending? So practice variation is different between the patients that were in the ProCoag trial and the patients that we'll have in the TAP trial. So pre-hospital TXA is standard in France, as well as routine use of fibrinogen concentrate. And then time from scene to trauma bay was significantly longer. And this is pretty crazy. I learned this because my fiance is French. He said no one moves at all in their ambulances, like when an ambulance is coming through. So ambulances just get stuck behind cars and no one moves. So it was really long in the ProCoag trial. So it took a while for the patients to actually get to the hospital, much longer than it would in the US, ideally. Similar trials are investigating the use of 4-factor PCC. So, data is evolving. And then on the flip side, obviously, 4-factor PCC is really expensive compared to FFP. There is the increased risk of thromboembolic events, as we saw in the ProCoag trial, and there was no difference in blood product consumption or mortality. So currently, as it stands, literature does not support the use of empiric 4-factor PCC in trauma patients, but more to come in a few years when the TAP trial comes out. We're getting there. So the fourth knowledge assessment, You receive a call from a resident about a 54-year-old male who was involved in an MCC, and he asked if you read the ProCoag trial, and he's wondering what dose to give and what would you recommend. So I'll kind of summarize this so we can move along. The first one is the 25 units per kilo, which they used in the study, and it should be used based on the decreased mortality. B, 25 units per kilo. However, it wasn't associated with reduced blood product consumption or mortality. And then C, a fixed dose of 1,500 units or 25 units. Perfect. B is the correct answer. Okay, we have just a couple more. So recombinant activated factor 7, or so this is, I'll refer to as like RFV2A, if you just keep saying that. But it works by binding to tissue factor, and it activates factor 10 on the surface of platelets. And this will convert prothrombin to thrombin, creating a thrombin burst, and that will ultimately convert fibrinogen to fibrin. And its benefit is that it exerts its effects locally at the site of vascular injury. Its activity is significantly reduced in acidosis. So over 90% of its activity is reduced when pH is 7. And we know that patients are oftentimes acidotic. So that's important to keep in mind. And then off-label use has been associated with increased arterial thromboembolic events. So the first trial, I'll kind of very quickly go over just because it's not really going to change our plan for anything, but it was done in 2005, and it was looking at 2 randomized controlled trials. One trial that included blunt trauma, and the other trial included penetrating traumas. And patients were randomized to receive factor 7, 200 micrograms per kilo, followed by 100 micrograms per kilo at 1 hour, and then an additional dose of 100 micrograms per kilo at 3 hours. And so for those of you who aren't familiar with like factor 7 dosing, that is a really huge, massive dose. And this was compared to placebo. You can see that both the blunt patients and the penetrating injury patients were pretty severe, and most of the doses were given within 6 hours. Looking at our blunt trauma patients, the primary outcome of RBC units transfused within 48 hours was reduced by 2.6 units in the factor 7 group compared to placebo. And they also were less likely to receive massive transfusion. There was no difference in thromboembolic events or mortality, and patients in the placebo group were more likely to develop ARDS. In the penetrating trauma group, there was no significant effect of factor 7 on RBC transfusions. Patients who received massive transfusion, thromboembolic events or mortality, or more multi-organ failure. A very, very similar trial was done in 2010 that looked at 2 patient populations, the blunt trauma group and the penetrating trauma group. And they randomized patients to the same dosing strategy of factor 7. Again, this is a relatively severe patient population based on their ISS scores, and most patients received the dose within about 5 hours. Breaking it down really exactly like the last trial, in the blunt trauma group, there was no difference in the primary outcome of 30-day mortality in patients who received factor 7. There was no difference between groups in any of the functional outcomes, including the 2 that I've listed here. So the ones I included were days alive and free of ICU through day 30, and multi-organ failure through day 30. There's no difference in the amount of patients who receive massive transfusion. And finally, there's no difference in thromboembolic events. In the penetrating trauma group, patients with penetrating trauma, there was no difference in the primary outcome of 30-day mortality. And similarly to blunt trauma, no difference in any of the functional outcomes. However, patients in this penetrating trauma group, factor 7 did reduce the need for massive transfusion within 24 hours after the dose. And surprisingly, there were significantly more thromboembolic events in the placebo group than in the factor 7 group. So the factor 7 group actually had 0 thromboembolic events. Again, a comparison of the 2 trials. And there's a lot more cons than pros. And it kind of seems like, why is that? Because those results didn't look that bad. First of all, the one benefit is that based on those trials, it looked like there was a reduction in the transfusion requirements and massive transfusion protocol. However, there was no mortality benefit or functional outcome benefit. Furthermore, based on the factor 7 being so again, unpredictable response because its activity is significantly reduced in acidosis. And then the results are kind of conflicting as to which population would have the greatest benefit. One of the trials, it looked like the blunt trauma patients had the most benefit. The other trial, it looked like the penetrating patients had a more benefit. So conflicting results. There is an increased risk of thromboembolic events in high-risk trauma patients. I know these trials didn't really highlight that, but historically, factor 7 has a high risk of thromboembolic events. And then lastly, I think, and almost mainly, is that it would cost $130,000 per dose for a 100-kilo patient. So that is an astronomical cost. I don't even think we probably have that much on hand to give them that big of a dose. Maybe we do, but that we have other agents. We have blood products. These were done in 2005 and 2010. Things have evolved since then. In conclusion, do not use. Okay, last one. We can blow through this too. So calcium, it's a coagulation, activates coagulation factors, and it's also a cofactor in the coagulation cascade. Blood loss and blood transfusions will result in hypocalcemia, again, as we kind of talked about with the citrate. And hypocalcemia is associated with increased mortality in trauma patients. At Erlanger, the current policy says to give 2 grams of calcium chloride for every cycle of MTP. The only trial that I'll talk about, hypocalcemia has been studied historically and shown that it's associated with an increased mortality in trauma patients. So I wanted to look at something a little newer. And this was a retrospective observational study of the trauma register, DGU, and it included adult trauma patients, and they were admitted to European trauma centers. All of the patients had their ionized calcium measured before transfusions, and you'll see that patients were pretty severe, or these were severe trauma patients. And kind of just to orient you to the graph here. So on what side is it? Left, right? I don't know, this side closest to me is going to represent hypocalcemia. And you can see that mortality is increasing for hypocalcemia, which we know and we would expect. And then it starts to go down. So mortality decreases during normocalcemia, and that's indicated by the green lines. It's kind of hard to see there, but the green bars. And then mortality starts to increase again once you get to, once the patient becomes hypercalcemic. So historically, we really think of hypocalcemia and mortality, but really we should be thinking of hypercalcemia and hypocalcemia being associated with mortality and targeting that sweet spot of normocalcemia. So what do we do with this information? Calcium has relatively minimal adverse effects, especially when we're using it in the trauma population. Might be a little bit different if you're like slamming an amp into like a floor patient versus a trauma patient, but in this patient population, it's relatively low risk. It's inexpensive, and normocalcemia has been associated with lower mortality. Differences in calcium gluconate and calcium chloride doses can cause dosing errors. So I've included the dosing right for you to see, but calcium chloride has a higher calcium content compared to gluconate. So the 1 gram is not equivalent as far as how much calcium you're giving the patient. Hypercalcemia is associated with increased mortality, so it's recommended, or we're recommending, to check iStats periodically. Based on this, administer calcium per the massive transfusion protocol, so 2 grams per cycle, to target normocalcemia, which is between 1.16 and 1.35. Last one. MK is a 44-year-old male who is in a semi versus motorcycle crash, and massive transfusion was activated. The blood bank is calls to let the team know that they're out of cryo. What alternative therapy would you recommend, and what is the purpose of giving cryo? The correct answer is D. So we would give fibrinogen concentrate 3 grams IV as a single dose, and that is to replace fibrinogen. So exciting times to be alive. there's a lot of really exciting upcoming trials. So the TXA crash is still coming out with trials. It kind of is pretty crazy, good for them. But the crash 4 is coming out next year. The first 2 trial will be comparing fibrinogen concentrate and PCC. We have the Feisty 2 trial coming out. And then there are a whole host of PCC trials on the horizon, with the TAP trial being the one that Erlanger is participating in. So in summary, what do we do? Essentially, just for time's sake, this is kind of what I've already presented to everyone, and are the recommendations. So TXA, early to severe trauma patients, we're giving 3 grams total. Oops. Oh no. Cryoprecipitate, we're not giving it empirically. You still give it during massive transfusion, or if it TEG is indicating it based on the CFFMA, or if their fibrinogen is less than 150. PCC, we're not using empirically unless the patient is in the TAP trial, then they can get it. For activated factor 7, no one's getting it. So lack of recent trials that really show its efficacy and safety. There's a high risk of thromboembolism, especially once we start getting into that hypercoagulable state of TIC. And then it's so expensive. And then lastly, calcium chloride, give it with massive transfusion to target normal calcemia. Okay, we made it through. Sorry, I was a little later than expected. There was a lot of trials. Thank you guys for your attention, and I can take any questions from the group. What we're all here for. Sorry, I'm taking a picture. Our current, like what we're currently doing. So our massive transfusion. Oh, here, I'm just gonna get out. So it gets put in with like the cycles